Good morning. My name is Jamie. I'm from Cedar Rapids, Iowa, and I'm a support group facilitator there. This morning I'm introducing Dr. Klopper. Just make sure you're in the right room. If you're here for the new indications and research data for radioactive iodine ablation, you're in the right room, okay? One thing I just want to make note of is if you have a question, please go to the microphone in the middle of the aisle so that way everyone can hear your question. And I guess let's get going. Dr. Klopper is an endocrinologist, is an associate professor at the University of Colorado School of Medicine in Denver. His research interests focus on treatment of poorly differentiated thyroid cancer, focusing on molecular targets in the nuclear hormone receptor superfamily and the activation of retinoid, PPARY, and vitamin D receptors to inhibit cell growth and potentially induce redifferentiation in aggressive thyroid cancers. He received his medical degree from the Emory University School of Medicine. He completed postgraduate training at the University of Colorado Health Sciences Center. Among his publication topics are molecular testing for mutations and improving the fine needle aspiration diagnosis of thyroid nodules, DNA profiling analysis of human thyroid cancer cell lines, and inhibiting anaplastic thyroid carcinoma tuber growth. Dr. Klopper is a member of ThyCa's Medical Advisory Council, so please help me give a warm welcome to him. Thank you.
Good morning. Thank you for the introduction. Thank you, as always, to ThyCa for inviting me. I have the privilege of working with the local group here in Denver. I go to their meetings quarterly, usually quarterly. Sometimes yeah, there you go. I don't know why you're here. You know everything I'm going to say. I've said before. So it's a real pleasure for me, and for anyone who was at the dinner last night, I have the privilege of being trained by Dr. Haugen, and I would just reiterate that, again, it's the patients. I mean, for those of us who are physicians, even if we have a lot of interest in research, I mean, it all comes back to the patient and your stories that prompt us and inspire us to try to figure out some of these issues. So thank you again. Gary asked me to speak on this topic, new indications and research data for radioiodine ablation. I'm not sure if there's a whole lot of new indications, to be honest, but there is some new research data. My understanding from speaking to some folks last night is this is somewhere between the 4th and 10th presentation on radioiodine at this meeting. So if you've gone to other sessions, hopefully you'll get a lot out of this. If you've gone to some of these earlier sessions, I hope that there'll be some pearl in here that maybe you haven't heard before. So by way of disclosure, I have done an advisory board. That's a one-time advisory board meeting with Genzyme. They make thyrogens, so it's important that you just know that I have that disclosure. I'm not on a continuing basis working for them, but in June at the last Endocrine Society meeting, I did an advisory board for them. So everyone's probably fairly familiar, if not intimately familiar, with this typical sequence of events in differentiated thyroid cancer. Someone has a nodule. However it's detected, and if it's positive for thyroid cancer, we recommend surgery. And then oftentimes, not always, but often there will be radioiodine remnant ablation, which is, of course, what we're going to talk about, and then follow-up monitoring and potentially more therapy depending on how things go. I want to start with when you absolutely don't need radioiodine, because not every patient needs radioiodine, and sometimes it's contraindicated. And let me also just state that I have probably too many slides. I mean, we have a lot of time, but feel free to interrupt me at any time. Just shout out, raise your hand. We don't have to go through all the slides and answer questions at the end. If something is compelling or burning, then just holler at me, okay? So when do you not need radioiodine? Well, medullary thyroid cancer. Medullary thyroid cancer doesn't respond to radioiodine, so that would be a very inappropriate use. Thyroid lymphoma also is not typically treated with even surgery, and radioiodine is not helpful. And then as primary treatment for thyroid cancer, it just is not effective. Radioiodine is really not effective for what we call bulk disease, and bulk disease can be a little bit of a squishy term. It's not absolutely well defined, but typically we'll say if there's thyroid cancer that's greater than a centimeter in its shortest dimension, that would be going to what we call macroscopic disease as opposed to microscopic disease. Radioiodine is really effective for microscopic disease. So again, this idea of can I avoid surgery, just give me radioiodine, that just really doesn't work. And so kind of in that context, if you have a hemithyroidectomy and there's a thyroid cancer found on that diagnostic procedure, again, radioiodine is not going to be effective to treat that other lobe if there's thyroid cancer in there. And we recommend, depending on the pathology, going back for a completion thyroidectomy. So this isn't in red because this is not an absolute contraindication, but in my opinion, it's a relative contraindication. If a patient has had multiple doses of radioiodine, there's really no absolute upper limit of the amount one can have, but it tends to be much less effective the more doses you get. And so indications that it's not going to be particularly effective is if a post-treatment scan is negative. If you've gotten a treatment dose of radioiodine, and we'll talk about how you come back for that post-treatment scan, if nothing lights up, it suggests that that radioiodine didn't get taken up by anything, and that means it's probably not going to be very effective. If after radioiodine there's no change in tumor size, if there's tumors that are large enough to seize and they don't shrink, and or if the thyroglobulin level doesn't drop. I mean, it's nice to have a pretty picture, but if you have a pretty picture but there's no change in the actual cancer, it sort of doesn't matter. It's not very effective. So again, radioiodine is an absolutely wonderful targeted agent that goes everywhere. I mean, it's one of our best treatments for thyroid cancer, but it doesn't always work as effectively as it should, and we shouldn't be hammering people with radioiodine just because that's the only tool that we have. Okay? Okay, so I'm showing in general the 2009 guidelines. I know that I call them the 2013 guidelines. I know we're almost at the end of 2014. That's a little rib on my boss, who's the head of the guidelines committee. I'm not showing those because they're not complete yet. They've been sent out for commentary, and there might be some changes. So you may have seen throughout this meeting some indications of what the 2014 guidelines are, and I've reviewed them in some detail, but I am showing you sort of officially the 2009 guidelines, which are in the context of this talk, very similar. And again, here's just the recommendation where routine radioiodine ablation in lieu of a completion thyroidectomy is not recommended. And this recommendation rating D means don't do it based on fair evidence or moderate quality evidence. Okay, so that's the official recommendation. So what are our goals? I mean, why do we give radioiodine? Well, the primary indication, again, is to destroy residual thyroid cancer, and generally that should be microscopic thyroid cancer, whether that's in the remnant. So even the best surgeon in the world usually leaves a little bit of normal and or possibly thyroid cancer tissue behind in that thyroid bed, and or if there's microscopic disease, generally in lymph nodes, to clean that up, to mop it up after the surgery. Okay? We give it to improve cancer-related survival. I mean, that's a good hard endpoint that we all care about. We want people to live, and radioiodine certainly can improve survival in many instances. To minimize the decrease of disease recurrence and metastatic spread, so whether it's persistent disease or recurrent disease, however you term it, we want to minimize that risk of sort of needing another surgery later or having the disease spread outside the neck. And then these in yellow, again, these are sort of relative indications, in my opinion, to permit long-term surveillance of disease recurrence. So some physicians will say, well, if I don't ablate and try to get rid of all the normal thyroid tissue, I can't really follow thyroglobulin levels. And that's really not true. We can follow thyroglobulin levels without radioiodine. We look for trends. If it starts rising, well, that's a bad trend. But in my opinion, just being able to more easily monitor someone is not a good enough reason by itself to give radioiodine. We've really got to fulfill these first two criteria. And then that third one, I mean, that's nice. It does definitely make it easier to know what's going on if you've ablated any remnant tissue. And then sort of dovetailing with that, this permitting accurate staging of disease, because without radioiodine, you may not know that there's small distant metastases, or although I'm going to show you some data where we can get that indication, but it can also permit, again, knowing where disease might be that's unexpected. So those are helpful, but in my opinion, not absolute indications for radioiodine therapy. So just in general, we've got our different types of thyroid cancer. The differentiated ones are on the top. Papillary is the most common. It usually does respond to radioiodine, as does follicular. Hürthle cell, it has this sort of bad rap for being a little bit more aggressive, which it is, and not responding to radioiodine. It tends to be a little bit more resistant, but we, in our practice, we certainly do treat people with radioiodine, even if it is a Hürthle cell carcinoma, because it's not completely unresponsive. And then again, medullary and anaplastic, I would throw lymphoma in there. They don't respond, so it would be a contraindication to receiving radioiodine. Okay, so this is older data, but just to sort of show you all comers, here in the yellow we've got patients who did not receive radioiodine, and then in the pink or purple, those who did. And so in terms of recurrence and preventing distant metastases, we see a significant reduction. So, I mean, this is sort of the general data that says this is good stuff. This is good stuff if you have thyroid cancer for decreasing that recurrence and distant metastases. So how do we determine who's going to get it? So part of it is based on staging. And many of you may know that thyroid cancer staging is a little kooky. Right? It doesn't make total sense in a lot of ways. So we've got this breakdown here where we've got age being a primary driver for stage. It's the only cancer where age is a primary driver for stage. So 45 is the magic number. There's actually some data that suggests that 45 is probably too young. That age should probably be closer to 60 or even 65 in terms of having poorer outcomes versus good outcomes. But for the official staging systems, we're still sticking with 45. And we've got this breakdown, like I just showed you there. And then also the stage 1, stage 2 being above this line, stage 3 and 4 being below this line. And so back in the day, the indication for radioiodine often was determined on low-risk disease versus high-risk disease, and that was defined as stage 1 and stage 2 were generally low-risk disease, although there are some caveats. Stage 3 and 4, high-risk disease. Well, again, let me just point out that there's a little bit of quirkiness to this. So technically, if you are 44 years old and you can have any lymph node metastases, that's what any N means here. So you can have any tumor size, any lymph node metastases, and as long as you don't have distant metastases, by this definition, you are stage 1. So your entire neck can be replaced with thyroid cancer, and you are stage 1. Conversely, if you are 46 and you have either a larger tumor with no lymph nodes or a small tumor with even one central lymph node involved, you are stage 3. That doesn't make sense. I'm much more worried about the young person with their entire neck replaced by thyroid cancer than the 47-year-old with one lymph node with a microscopic deposit. So, again, the staging is somewhat helpful for getting a global sense as to how this patient may do in terms of death, but it really is not particularly helpful, and so the field has changed in terms of determining who's going to require radioiodine and do better with radioiodine. But based on this kind of staging, I'll just show you older data that shows that for those folks who got radioiodine, so the red line is those who got radioiodine, the yellow line is those who didn't. This is overall survival. In high-risk disease, stage 3 and 4, they did better. This line is higher. They have a greater overall survival. And then even in stage 2, radioiodine did improve the overall survival. In this retrospective study, meaning that it was lots of centers and they just looked back over their experience, those with stage 1 did not have a benefit of survival. Okay, that doesn't mean it doesn't benefit them, but in this analysis, they just couldn't see that. But again, I think everyone would agree that if you've got 20 lymph nodes in your neck as a 25-year-old, radioiodine is probably indicated. Okay, and so that's where this falls down a little bit. Yeah?
Just a question about how, some of these studies, you're sort of choosing to do radioiodine on people who are worse in general, right? And there could be sort of, these gradients of decision-making on that. So you're not really saying, I'm doing a randomized study and, double-blind everybody and saying, putting these people into very random categories. So, my guess is that radioiodine might be even more effective than we know because we bias it toward the worse off people, right?
Yes, so the question and comment is that these are bad studies, which they're not bad studies. No, I'm being unfair. No, the point is well taken. These are retrospective studies. These are not prospective studies where we say we're going to make a treatment decision, you're going to go into one of these groups, and we're going to see how it turns out, okay? There are lots of biases as to why patients may or may not have gotten radioiodine. Maybe the stage 4 person in one of these studies had horrible heart failure, and you said, well, I'm not going to hurt you with radioiodine because you're going to have some other problem. So there's lots of caveats to retrospective studies. There are biases based on physicians, and I'm going to show you some of those biases with some of the newer data that determine who gets radioiodine. So yes, radioiodine is probably more helpful, especially when we select patients based on their aggressiveness of disease. So I totally agree with the comment that these don't paint the best picture as to how we should base our decision making. And also, we know that most patients at least in the time of follow-up that we're going to see patients, don't die of thyroid cancer. So for a young person, even if they have aggressive disease, I'm not so much worried about, are you going to die in the next year? It's, can I help prevent you from having a significant problem because you've got so much time to live? And that's really a more practical, important factor. And that is not taken into account in any of these studies because it's too hard to sort of follow, okay? But yeah, no, I mean, I agree. So this is, I think, what you're actually speaking about, this risk stratification, and this is the way the field is moving, is we need to be smarter about how we label and risk stratify these patients, okay? We just can't say, you're stage 1, you don't need radioiodine, you don't need TSH suppression, you're going to do great, okay? We need to risk stratify. And then we also need to talk about their response to that therapy for how we're going to follow them, and that's a little bit outside the context of this talk, but here we have patients very low risk, okay? Young person, a small tumor, completely confined to the thyroid, stage 1. I'm going to show you that the guidelines would say that patient doesn't need radioiodine. They very likely are completely, we don't throw the term cure around a lot, but they've had adequate therapy with surgery alone, okay? But then let's go over here to this intermediate risk person. Young person with a big tumor, okay? Invasion outside the thyroid, maybe some lymph nodes involved. Technically, they are stage 1, but they have intermediate risk, and they could be, under the age of 45, they shouldn't be stage 3, but if they're 46, they could be stage 3. So again, this idea that staging does not really compartmentalize patients particularly well. We need to look at all of the factors of the size of the tumor, if it's behaving badly by trying to go outside the thyroid, if the lymph nodes are involved. There's even data on sort of the size of the lymph node deposits. 2 millimeters, there's this cutoff that's at least been proposed that's almost like they weren't there at all, and if it's bigger than that, then that's more concerning. And then we have these high-risk patients. So again, this risk stratification is really important, and we can't just compartmentalize people and say, you're stage 4, it's going to be terrible because if you have a great response to therapy, it might be okay. Yeah?
Do you have any data for like the pediatric population? I know there's so very few of them, but a lot of them are considered, low risk or, stage 1.
Yeah.
But most of them have received RAA just because of the extent of their disease.
Right. So the question is about pediatric thyroid cancer, and it's noted that there's limited data. There's limited data in lots of pediatric disease, unfortunately. So pediatric thyroid cancer, it's kind of interesting. It tends to present very aggressively, larger tumors, relative to the to what we see in adults often, sometimes invasion, lots of lymph node metastases. So an adult has a lymph node metastases anywhere, if you look at the study, 30 to 60% of the time. There's kind of a broad spectrum there. Kids, it's usually 60 to 80% of the time. Adults, the presence of distant metastases at the time of diagnosis is 2 to 4% of the time. In kids, it's closer to 5 to 10% of the time. So they present very aggressively. It's scary. However, they tend to respond very well to radioiodine. The tumors tend to be very, what we call, well differentiated. They're acting like sort of normal thyroid cells, except for the whole cancer part, but they're taking up radioiodine, and they tend to respond very well to radioiodine, and they tend to do very well in terms of longevity. Now, the biggest series I'm aware of is out of the Mayo, and over 50 years they had something like 35 patients to indicate how rare this pediatric thyroid cancer is. And I think only one patient in that series died after, over a 20-year follow-up, okay? So that's great. The problem is if you're 8, what happens when you're 40, okay? I mean, so it's just hard to follow patients that well. So, I mean, again, that's kind of what I worry about. I think that if the pediatric patient has a good surgery, they get radioiodine and they respond, even if the disease isn't totally cleared up, I think they're going to do very well for a long time. But we don't really know, if that will truly shorten their length of life. Again, not at age 20, 25, but as they get past that 20-year mark. So I think it's a little bit unknown, but again, what I can say is that they present aggressively, they tend to do very well. There's a question over here. Yeah.
Risk stratification, so over 45 automatically.
Well, so by staging, you are, unless you have a very small intrathyroidal tumor, by staging, you're almost always going to fall into that high-risk category if there's any lymph nodes involved. But again, we have this risk stratification where you're probably at least going to be an intermediate risk. based on this risk stratification. But then the next phase is response to therapy. So you could have a terribly aggressive tumor, invasion outside the thyroid, lots of lymph nodes involved. And I've had patients who would meet stage 4 staging, bilateral lymph node disease, an invasive tumor, who've had just a great surgery, margins are clear, lymph nodes are removed, and I've pretty much always given them radioiodine, but I'm not sure it actually did that much for them because their surgery was so good. So they had a great response to therapy. All right? And so that's where the field is kind of moving, is it's not you're put into this box where, well, you have stage 3 or 4 disease, you're going to do terrible. If you have a great response to therapy, you're probably going to do very well. If you have stage 1 disease and an inadequate surgery and you still have a bunch of lymph nodes involved, you're probably not going to do as well. Okay, so that's how we're thinking about these. Okay, so this is not meant to be, read and digested here in this presentation, but I think I wanted to show it because it kind of gives you an indication of the complexity, okay, and how we make these recommendations. So the table is nice because it is something that if you're sitting there thinking about a particular patient, you can kind of read down through this table and say, what was the size of their tumor? If I can get the mouse going here. What was the size of their tumor? What's the expected benefit? Are they going to have a decreased risk of death? Again, in T1 tumors, no decrease in recurrence with radioiodine as long as there's no lymph nodes. And then a lot of this, again, is kind of conflicting data. So age over 45, bigger tumors, distant metastases, yes, there's going to be an improvement in survival and a decrease in recurrence. But there's a lot of this stuff where, selective use is what's described. And so that can, I think, hopefully give you an indication of why there's a lot of variability, because we just don't have great prospective data to say you absolutely are going to benefit, you absolutely are not going to benefit, et cetera. Okay? So the guidelines from 2009, and again, these are going to be similar. Radioiodine ablation is recommended for high-risk disease, stage 3 and 4 disease. All patients with stage 2 disease under the age of 45, because by definition they have distant metastases. If you're under the age of 45, and you can't be stage 2 unless you have distant metastases, and those patients clearly will benefit. Radioiodine ablation is recommended for selected patients with stage 1 and 2 disease. So many patients with stage 2 disease over the age of 45, so those are relatively larger tumors, but still contained within the thyroid. And that's probably shifting a little bit with the new guidelines as to whether they really need radioiodine. Extrathyroidal or vascular invasion, aggressive histologies, and then multifocal disease and nodal metastases. Again, I think small microdeposits in central neck nodes, a lot of experts would not necessarily give radioiodine, but larger metastatic nodes, especially in the lateral neck, most people would give it. And the 2009 guidelines were the first guidelines that said there are indications where you should not give radioiodine, that the harm outweighs the benefit. Every medication, aspirin, everything, always has a risk-benefit ratio. So radioiodine is not recommended for unifocal cancers, less than 1 centimeters, and now, again, we're sort of loosening that up to maybe even larger tumors as long as they're intrathyroidal. And again, even if it's multifocal, if it's all contained within the thyroid, the primary tumor is less than 1 centimeter, then it's not necessary to give radioiodine. Okay? So, what other factors should influence our decision? Because again, we've shown you sort of the complexity of that table. So this is some relatively new data. This is data from Megan Haymart, who's at the University of Michigan. And what she looked at was not necessarily the medical indications, but just kind of the variability and why there's variability in the use of radioiodine. So I think it's pretty interesting data. So this is an article that looks at data from a group of hospitals that are part of this national cancer surveillance network, and just what was the rate of radioiodine delivery in patients, just overall. So there was an average delivery rate of 80% of radioiodine, and so that's what this line is right here, okay? So this is the estimated probability of receiving radioiodine, all right? So 47% of the hospitals used radioiodine more commonly than this average rate, and 17% used radioiodine less commonly than this average rate. So we don't know why. I mean, we don't know anything really about the details of that, but it just shows you that there's a lot of variability, and I'm not sure that I have a great handle as to why, okay? Maybe it's the types of patients that happen to go to those centers. Maybe it's something about the sort of culture and the training of the physicians who practice there, but there's a lot of variability, and it's not necessarily a bad thing, but I'm not sure it's necessarily good either, because I'm not sure there's great reasons for this variability, and that's, again, where these kind of guidelines, they're good to provide direction, but they are a little bit squishy. Selective use, consider use. So it just, again, gives you an indication as to why there's variability. So I'm bringing this table back up again just to show you that in the minds of the guidelines committee members, we see that there is no risk of no improvement in death if you have a small intrathyroidal tumor by giving radioiodine. And really, in terms of good quality data, there's very rare instances where there is a clear decrease in the risk of death. Distant metastases, very aggressive tumors. Okay, so that's kind of the context for the next study I'm going to show you. There are tumors that we know, to the best of our ability, are likely not going to receive a lot of benefit to radioiodine therapy, patients and their disease. And there's a lot of selective use, but there are very few instances where clearly radioiodine is going to be very beneficial. Okay? So what are the factors that influence radioiodine use? So this was a survey study. It was a survey of physicians from that same National Cancer Database. And what they did is they actually talked to the surgeons, because that surgical information is very easy to capture. The patient had a thyroidectomy for thyroid cancer. And they asked those surgeons who was going to be following up your patients, and so, because there's referral patterns. And so they said, these are the people that you should talk to get an idea as to why they give radioiodine. Okay? So there was a 63% response rate, which is pretty good, over 500 physicians. These are the characteristics. They were, on average, 75% white males. They had been in practice for 20 years. Here's the types of physicians. Most were endocrinologists, but some nuclear medicine docs sort of deliver that radioiodine, not necessarily, with the patient not necessarily seeing an endocrinologist. 71% of this other category were radiation oncologists who can deliver radioiodine, and the minority were oncologists. And here's the breakdown of whether they were in private practice, academic centers, et cetera. Okay? So this was the percentage of physicians who described these different concerns as the reason to give radioiodine. Okay? And so I want to show you here that the fifth most common reason was worry about patient death. Well, patient death is very rare with thyroid cancer, okay? And so that sort of jumps out at me as opposed to some of these other reasons. And also, this was higher than what the physicians' perceived concern was about the patient worried about the death. The physicians were more concerned than the patients about death, and that's why they gave radioiodine. Well, in my mind, that's kind of backwards, right? I mean, I'm worried about my patients, and I want them to do very well, but I would think that the patients would be more worried about their own necks than, I'm concerned, but it's your neck, right? So, that to me is somewhat striking in the decision-making process. And, we're human too, right? And so that fear is not just present in patients. And I don't want physicians to be robots, but that is a little bit concerning if I'm just giving this therapy because I'm worried about you dying when there are some diseases where we have evidence that it's probably not going to help. And anything that doesn't help probably hurts, okay? So again, this worry about death, is this very important to you? So the physician consideration of patient worry about death and physician concern about death themselves, we do see that with the increasing with the increasing volume, you see 0 to 4 patients per year with thyroid cancer versus 100 or more. The more experienced physicians have a decreased worry about that, and they don't quite worry as much about their patients worrying about it. But most endocrinologists probably see in this range here. And so, again, that concern, that bias is playing a role in this decision making, and it just, again, demonstrates, I think, some of the variability that you may experience as you're talking to other patients, talking to your physician, okay? Okay, so why not just treat everyone? This stuff's a magic bullet. If you've got thyroid cancer and that radioiodine is going to go to the thyroid cancer, why not just treat everyone? Okay, well, because, again, if it doesn't help, it only hurts, and there are potential adverse effects of radioiodine. So I think everyone certainly knows about salivary gland damage, dry mouth, salivary gland tenderness, and that's certainly something that we talk about and is very distressing when it happens to patients, especially here in Colorado in our dry climate. I think it maybe even a little bit worse. But There's other factors as well. So dental problems, dental caries. This is one that I think is missed with some frequency, this epiphoria. This is increased tearing. So there can be damage and scarring to one of the lacrimal ducts on the insides of the eyes, and it just scars down. And so it's not that there's increased tearing, it's just that the tears aren't draining appropriately, and so it feels like there's tearing all the time. And unfortunately, patients will say, oh, I've been dealing with this for, 6 months. And it might be delayed, so it's a little bit off the radar of the radioiodine, and it's a relatively, easy for me to say, it's a relatively easy fix where the ophthalmologist can open up those lacrimal ducts. So something I try to counsel patients on, that this may be something that you experience in the future, but if you sort of say, gosh, I'm just tearing all the time, maybe it's my allergies, well, it might not be your allergies. And gonadal dysfunction is actually generally transient. That's pretty minor concern. Marrow suppression, you got to give pretty big doses. Pulmonary fibrosis, in the context of extensive pulmonary metastases, if there's a lot of radiation that gets into those metastases, it could damage the lungs surrounding it. And then this possibility of secondary malignancy. I mean, this is radiation that does go everywhere. It's not zero. So let me just show you this data. This is out of Memorial Sloan Kettering, where they treat lots of patients, and they treat lots of patients with radioiodine. And this is just looking at the salivary gland side effects. And so dry mouth, altered taste, etc. I think this is actually kind of reassuring, where even though we talk about it all the time and patients worry about it appropriately, it's relatively rare. So 40% had any symptom, but still less than the majority. But this true salivary swelling, salivary pain, et cetera, is relatively low, 16% and 6%. And what's pretty reassuring is that in the vast majority of these patients, high 80s to low 90s, it resolves. So, I mean, again, that's kind of good to know. The secondary malignancy, this is this analysis where they sort of make predictions about what the anticipated secondary malignancy rate is, and with kind of the known rate, which is very low, as opposed to kind of the background rate. So here is what the expectation would be for no radioiodine, of just getting any malignancy after you have a history of thyroid cancer versus when you get radioiodine. So this relative risk is certainly higher, but the absolute risk is very low. Okay? So a 15 to 20% relative increased risk, someone who got radioiodine versus someone who didn't. But the absolute risk is 10 new cancer cases per 1,000 patients over 10 years. Okay, so it's not zero, but what I tell patients is, I'm not going to withhold this therapy for the cancer you have now because of a very low risk of cancer in the future. But I think what this is important to note is that it's not zero, and if radioiodine isn't effective, don't give it, because there are risks besides all the salivary gland stuff, and so we want to have some good indication that it helps, right? If it doesn't help, it only hurts, even if it's just time and money. Okay, so what other information can we use to determine the utility for radioiodine, or the dose? So this is a graph that was kindly given to our group by Dr. Carol Spencer at the University of Southern California. And this just shows you what the expected drop in thyroglobulin is after thyroidectomy. So thyroglobulin is the protein. It's only made by thyroid tissue. It's made by both normal thyroid tissue and thyroid cancer, so we can't really use it preoperatively to determine if someone has thyroid cancer. But once the thyroid's out, and especially after radioiodine, I mean, it's great. We assume any thyroglobulin is coming from thyroid cancer. And you can see that there's a rapid drop. Here's where the thyroidectomy occurs, and then here, by about 6 weeks, we've pretty much reached the low point of where thyroglobulin ought to be. Now, this is for patients who are on thyroid hormone, okay? And our practice at our institution is to send everyone out after surgery on thyroid hormone. It's partly to get this information. So 6 weeks is a very nice time point to follow up, because it's given patients time to recover from their surgery. It is a good time to check the steady state of their thyroid hormone dose that they've been discharged on, because it's about 6 weeks to reach that steady state. And we can also get a sense of what this thyroglobulin level is at that visit. Okay? So, can that value help us in determining if patients should receive radioiodine? So this is a study looking at patients who had a very low thyroglobulin, undetectable, after thyroidectomy. Okay? And so the sensitivity of the thyroglobulin assay in this study, I believe, was 0.5. Ours is 0.1. So, if it says less than 0.5, that's technically undetectable by this assay. Maybe it's 0.3, but low. Low thyroglobulins, okay, post-surgery. So it was retrospective again, 751 patients from 99 to 2005. All patients had a very low thyroglobulin postoperatively. So there were 80 low-risk patients, meaning that they didn't have extensive lymph node metastases, intrathyroidal tumors, et cetera. And 35 patients received radioiodine, 45 patients did not receive radioiodine. And kind of going back to the point that was made earlier, we don't really know what the decision-making was in this process, and so there are other factors that may have played a role, but we do know that they either got it or they didn't. And there were 218 intermediate risk group patients, so either larger tumors that were intrathyroidal, some lymph node metastases, et cetera. So the majority, 135, got radioiodine, and 83 didn't. But again, all of them had this low thyroglobulin postoperatively. And what this shows is that there was no difference in whether they had overall survival or disease-specific survival or recurrence, et cetera, between the low-risk patients and the high-risk patients, okay? So that undetectable thyroglobulin was very reassuring that they had, again, a great response to therapy, that surgery. They had a great surgery, okay? And so the radioiodine didn't make a difference for recurrence, disease-specific survival, et cetera. So I think that thyroglobulin is quite useful. Now, it doesn't mean if you have a low thyroglobulin you shouldn't get radioiodine, but it should at least make us pause or consider lowering the dose. Again, we'll talk about dose later, all right? Just because you have a lymph node doesn't mean you need to get blasted with 150 millicuries of radioiodine, all right, is what I think it kind of tells me. So let me show you this case. This is a real case. This is a case I just had in the last month. So the surgery was in August. The patient had a near total thyroidectomy in a central neck and right lateral neck dissection. It was a follicular thyroid cancer, 2.1 centimeters. There were 6 out of 35 lymph nodes with several large deposits of tumor, some central nodes, et cetera. There was no extrathyroidal invasion. The surgical margins were clear, and I write, this is from my note, I write pending because I'm just talking to the patient about the pathology and what I think ought to happen. And I told this patient, it is very likely I'm going to recommend radioiodine because you've had these lymph node metastases. Some of these lymph nodes have a lot of tumor deposit, et cetera. The stage was stage 4A. And so then I said, well, let's get some more information. And I presented this at our conference. So, do we give radioiodine? Everyone said yes, and we talked about the prep and the dose. But before we do that, here's her information. So her thyroglobulin read is greater than 5,000. Okay, something is going on. Okay, that is not normal, and we need to figure that out beforehand. All right. So this, to me, is why this is incredibly powerful. So the low level may help us say, maybe you don't need radioiodine if you're kind of on the fence, or maybe I can lower the dose. This is telling us that something bad is happening. And so this is where endocrinologists need to think more like oncologists, got some imaging, got a PET CT. And this is actually on the iliac wing, kind of right at the pelvic girdle. And this should not be there. Here's a large PET positive lesion. And there it is on the CT portion. So symmetry is the key to beauty, and this is not symmetric. You've got this large lesion here. And so this is a 5 centimeter, very likely follicular thyroid cancer metastasis. And it's really important to know this because radioiodine is going to be incredibly ineffective, if not useless, in this patient, because it's just like we don't give radioiodine as primary therapy for a thyroid cancer. This is kind of like a thyroid sitting in that bone, and it just won't be very effective. And all the radioiodine would go to that spot just because it's such a huge mass. And there were lots of other spots, too, that lit up that probably wouldn't get any radioiodine benefits. So this patient's actually going, just met with our orthopedic oncologist to see if surgical resection was a possibility, get rid of this tumor mass, and then proceed with radioiodine. Okay, so again, I think that postoperative thyroglobulin can really help us, get a sense as to what disease might be there and how we should proceed. Yeah?
Question on how come radioiodine is not effective on bulky tumors. Is it just, because I would think that any cell that is iodine added could theoretically, get in there, but what is it if these tumors are just hard and they don't have a proper blood supply or something like that? Or how physically don't go in?
Yeah, so the question is why is radioiodine not effective for bulky tumors? I think part of it is that, even though we might give a relatively large dose of radioiodine, when you have that much tissue mass, it just only goes to a portion of it. There may be some insulation just by the volume of the tumor itself. Again, like in this case, for example, there would be so much avidity for that radioiodine to go to that spot that there's lots of other microscopic spots that may not really sort of see the radioiodine. So I think all of those reasons are why it just isn't effective. Now, in hyperthyroid conditions like Graves' disease, again, that's not a malignancy. And I mean, I think also just malignant cells are hardier. I mean, they're just less responsive to this type of damage. Those cells are actively sucking up radioiodine itself, and so a non-cancer that's really very avid, I mean, I think that's why it's more effective. And you know, that tissue mass in a Graves gland, it may shrink, but it doesn't disappear. We want all this stuff to disappear. So it's a little bit of a squishy answer, but I just sort of know from experience it doesn't work, and I think those are the reasons why. Yeah.
Can you use the thyroglobulin before and after surgery?
So the question is about using thyroglobulin before and after surgery with antibodies. So again, I mean, my practice, we don't really use thyroglobulin before surgery. You could look at this case and say it may have helped, and maybe it would, but it wouldn't necessarily have changed much except maybe pushing up the timeline of looking at this thing. But there's data that shows that the thyroglobulin in a large benign multinodular goiter clearly overlaps with a small cancer. So it's not really helpful preoperatively. Postoperatively, the antibody issue, you can utilize that, but we tend to send our blood samples to a special lab that can kind of get around the antibodies. It's called a radioimmunoassay, and it's sort of a manual separation of the antibodies from the thyroglobulin itself, because what happens is the antibody is sort of complex in that test tube, and the thyroglobulin is falsely lowered. So when we see antibodies on that postoperative thyroglobulin, I say, ugh, now I got to redraw the blood and send it off. But that only occurs about 20% of the time, so and it's more expensive, and so it's not a standard assay. Yeah. Okay, so how do we prepare patients? Okay. So low iodine diet. I tell patients this is one of the biggest side effects of your therapy, okay, because everything that tastes good has iodine in it. This is a study just to show you that these investigators, they had first of all correlated spot urinary iodines with 24-hour urinary iodine collections. I don't know if anyone's ever collected a 24-hour urine. It's kind of a pain. So spot urinary iodine is preferable. And what they showed is that when they had patients on a strict low iodine diet, and this is I can't remember if this is, I think this is a Korean study, but anyway, you know, where there's a lot of seafood, high iodine content diets. By 6 days, they had dropped to this level that was considered to be appropriate for radioiodine administration. So these 2-week, 4-week slogs of low iodine diet is probably not necessary, and I've switched to just saying 1 week. Be good about it for a week, and that's probably adequate for depleting yourself for a low iodine diet. Okay. So what are the effects? So there's never been a study that showed survival or even recurrence was improved with a low iodine diet. All right. Conceptually, it makes sense. The idea is that we only want the thyroid cancer cells to see the hot stuff. Okay, and they don't care whether it's what we call cold iodine from your diet or from some kind of supplement. It'll suck up that iodine. But again, we want to enrich the hot stuff, so we try to deplete the body of the cold stuff. Okay, the hot stuff being the radioactive iodine. So this was a study that just, again, retrospectively looked back at standard versus low iodine diet. It was only 4 days, but the low iodine diet got to the level that they wanted. And this is looking at patients at the time of their ablation and how much radioiodine was detected kind of in that area of the thyroid bed, and then looked at it 6 months later at this sort of evaluation period. And so there was a statistically increased detection of the radioactivity after the low iodine diet in the thyroid remnant. That's what this is indicating here. These weren't statistically significantly different, but there was a trend for a lower thyroglobulin 6 months later. And for those patients who did not have any detectable uptake in their neck, there was, again, a statistically significant increased rate of no detectable radioactivity in the thyroid bed. So again, no long-term follow-up survival analysis, but this at least suggests that the conceptual idea is valid. And so again, I think it's reasonable to do a low iodine diet. For me, in my practice, I actually push the low iodine diet more for any kind of whole body scanning that we're going to do afterwards, because I don't want iodine contamination to call that whole body scan negative when it may actually be positive, and that would push me to give more radioiodine when I would otherwise not give it if the whole body scan was negative. Does that make sense? So I do recommend it for treatment, but I really sort of stress for when I do whether it's a year, whatever time point, if I'm going to do a whole body scan, I really want patients to be on a low iodine diet. And everyone rolls their eyes at me when I say that, but I think it's helpful. Okay?
Low
Yeah.
iodine diet.
Yeah.
So if you're doing the thyrogen scenario and staying on these meds which contain tons of iodine, then do you recommend a different low iodine diet duration or anything like that?
Yeah, so the question is about staying on the thyroid hormone that has a ton of iodine. Maybe I would quibble with you a little bit about a ton of iodine, but no, I don't. I just say, the whole point of thyrogen is so you can stay on it, and so I wouldn't go prescribe a more expensive thyroid hormone preparation. I would just do the low iodine diet and stay on the thyroid hormone. Yeah.
So you wouldn't say like stay on it 2 weeks or something like that?
No. Nope. Yeah.
What do you think about measuring urinary iodine before you give the radioactive?
So the question about measuring urinary iodine before low iodine diet, if it's a high-risk patient that I am worried about and I really want that dose of radioiodine to be as effective as possible, sometimes I will do it. If the patient tells me I take some kind of supplement for thyroid health, which probably doesn't make sense if you don't have a thyroid, but that sometimes those have kelp and all this other stuff. I'll check it. If they've had a contrast study, CT scan for example, even within the last 3 months, even though most data suggests most of that's cleared by 6 to 8 weeks, I'll check it, and I'm looking for a level, at least in the assay we have, of less than 150. So I definitely have checked that and then said, oh gosh, let's wait another couple weeks before we treat you. Those patients stay on their thyroid hormone because, again, I don't want patients to be hypothyroid for that much longer, screwing around with T3. And again, those patients who stay on their thyroid hormone, when we wait longer and they go on a low iodine diet, the levels drop for sure. So maybe that's reassuring for you. It's reassuring for me. So I think it's useful. I don't do it in every patient. If it's, again, sort of a intermediate risk patient that I say, yes, I'm going to give you radioiodine. They haven't had any CT scans. They don't have any kind of specific iodine, rich diet or supplement. Then I don't necessarily. Yeah. Okay. Right. So preparation. So we want, what drives iodine into cells? It's thyroid stimulating hormone TSH, and so that can be achieved. Raising the TSH can be achieved by taking people off their thyroid hormone, where you lose the negative feedback to the pituitary, or by giving recombinant human TSH or thyrogen. Okay? And for remnant ablation, again, remnant ablation does not imply that we're treating aggressive disease or distant disease. Either can be used by guidelines. So the way this works is here's our thyroid follicular cell, and whether it is endogenous TSH from your pituitary or thyrogen, this comes in and binds to the TSH receptor, and that upregulates the sodium iodide symporter. So that's where the iodine goes in, and whether it's radioiodine or cold iodine, that's going to get sucked up into the cell. And then all these enzymatic reactions up at the top here, clinically it's not very important, but that sort of organifies this radioiodine and traps it in there, and that's why the radioiodine gets trapped, and then it sits in there and kills the cells. Okay? So when radioiodine doesn't work, what's probably happened is the thyroid cancer has disrupted the sodium iodide symporter, and that's known to occur. And so if that thing doesn't work, if that pump doesn't work, then you can't get iodine into the cells, and that's probably why there's that resistance. And so some research is aimed towards improving the function of that sodium iodide symporter so that we can use radioiodine again in the future. And that's been challenging. So that's the recommendation. So where did this recommendation come from? Again, relatively old data, but I think important to recognize. 63 patients, they were all considered to be low-risk disease. They pretty much all had papillary thyroid cancer, and 30 were treated with withdrawal and became hypothyroid, 33 with thyrogen. They all got 100 millicuries, and they all got 8-month testing afterwards to see what their whole body scan and thyroglobulin showed, and it was the same. Okay, so this was the study that got thyrogen approved. And what's important to recognize is that, sorry this doesn't show up very well, but 35% of these patients did have some lymph node metastases, generally in the central neck. So lymph node metastases does not mean you should not get thyrogen or it's contraindicated. Those patients were included in the original study. Okay? So 100% successful ablation in all patients. All patients had a thyroglobulin less than 2 prior to that stimulated study, and there was no difference in the stimulation. And then just to show you that there has been follow-up for these patients, not 10, 20-year follow-up, but that we would love to have, but almost 4 years, they were still all the same. Okay, so there's at least some relatively long-term data that suggests that they all did as well. This is a theoretical benefit. There was a lower dose to the blood of radiation that was detected when patients got Thyrogen, probably because when you're hypothyroid, your renal function decreases slightly, not to any clinically significant degree, but that clearance of radioiodine may be slower, and so there might be more circulating radioiodine. Now that's an argument why some people think withdrawal is better because it circulates more. Again, the outcomes look the same, but maybe this is a little bit of a safety profile. Now the clinical significance of this I have no idea, but the company certainly pushes it, okay? So some to consider. Okay. So that's just a summary of basically everything I showed you. In those patients that require hospitalization, if patients are hospitalized, then they tend to clear the radioiodine faster for whatever doesn't get sucked up, and they tend to go home quicker. So hospitals like that too. Okay, so some patients, though, are not appropriate for recombinant human TSH. Distant metastases, very aggressive disease, it just has not been adequately studied in those cases. And so the gold standard is to withdraw and make patients hypothyroid. So how do we do that? And so our practice follows what this study showed. They looked at patients who either had a thyroidectomy and were not started on any thyroid hormone after their surgery, or patients who had a thyroidectomy, had been on thyroid hormone on suppressive doses for a year or whatever time period it was, and then took them off their thyroid hormone, and how rapidly did that TSH rise. Now, the goal TSH for us is greater than 25 to sort of feel like we're getting adequate stimulation of iodine into those cells. And so here's the graph. And so the top line here is those patients who were just after thyroidectomy, and these are the patients who had been on suppressive doses of thyroid hormone and then it was taken away. So you can see that this rises more quickly, but within about 3 to 4 weeks, they've kind of reached the same level, and here's the TSH above 50, okay? So, and then this is in graphical form, and what we're seeing here is by 3 weeks, regardless of whether you were just not started on thyroid hormone after your surgery, or if you were taken off thyroid hormone, you still reached a level of clearly above 25 after 3 weeks. So this is, again, why we send people out on thyroid hormone, because we just, if we're going to withdraw them to give them radioiodine, we just know it's going to be 3 weeks. So you don't have to go, first of all, I've seen so many patients who were not started on thyroid hormone, their appointment gets delayed for whatever reason, and then 3-4 months later, they come in and they've been hypothyroid the whole time. And that is not a good situation, okay? And then I'm going to show you this next study that showed the comparison of quality of life and effectiveness of recombinant human TSH versus this T4 withdrawal versus the T4 plus T3. So the way we used to do it, the way I was trained to do it, was if the half-life of thyroid hormone is so long that it takes 6 weeks to reach steady state, we would stop T4 6 weeks prior to radioiodine. And to bridge that gap so they weren't hypothyroid, we would use T3 until 2 weeks before and then take that away. Okay, well, that's a little bit convoluted and the levels are a little bit all over the place and there's just more stuff to remember. The idea, though, is that people would be less symptomatic. So this is a study looking at the ablation success rate, and what this top line shows is that it was all the same, okay? Whether they did T4 withdrawal for 3 weeks, this longer withdrawal with a T3 bridge, or recombinant human TSH, they all had the same ablation success rate, okay? What this study shows is symptomatically, how did patients feel about their quality of life and how did they do symptomatically? And clearly, recombinant human TSH is better. These numbers being lower indicates that they felt better, and that's known. But what I want to show you is that this was the same. The thyroid hormone withdrawal versus this T3 bridge. So this idea that you're going to minimize symptoms with this T3 bridge, I think, is relatively unfounded, and I can just tell you it's just a pain. I mean, it's more money, it's, when do I go off this, and when do I start that? And so, again, 2 weeks on T3 versus just 3 weeks off, I mean, it's much easier. So that's what we do, okay? So if you need to go off your thyroid hormone for another dose of radioiodine, I don't think you need to mess around with this T3 bridge, and I don't do that anymore. All right, so then what's the dose? So we got new data on this, relatively new data on this. It's still controversial, and this is the 2009 guidelines. So the minimum activity, 30 to 100 millicuries necessary to achieve successful ablation should be utilized. Well, 0 to 1,000. I mean, it's a pretty broad range, okay? And so that causes people angst. I mean, it's pretty different, 30 versus 100. So what do you use? Again, the lower recommendation is that if it's a bigger, badder tumor, consider a higher dose, which I agree with. So these are the two studies that came out in tandem in 2012 with the New England Journal of Medicine. These were very well done studies. These were prospective, randomized, controlled studies where patients were randomized to either getting 30 or 100 millicuries. They all had relatively low-risk disease, kind of like the initial Thyrogen studies. But again, some patients with relatively larger tumors, 10% had tumors greater than 2 centimeters, and 20% had lymph node metastases. This is in the upper study. And some of these patients in the lower study had tumors even greater than 4 centimeters. 15% had lymph node metastases. So these are not just intrathyroidal tumors. And again, randomized to 30 or 100 millicuries. And the bottom line is that they did the same. It was the same efficacy in terms of ablation. Now, again, we don't have long-term follow-up. We don't have survival data. But for that sort of 1 year post-operative, post-radioiodine studies, it was all the same. So pretty reassuring that 30 looked equivalent to 100 in appropriately selected patients. And so that's the other thing that's starting to come out now is we have to teach people how to appropriately select patients. And it's not that easy, but it's something that we as physicians have to do. This is a meta-analysis. So meta-analysis has problems because all the studies are designed a little bit differently and the patient populations may not be exactly the same, but the power of meta-analyses is that it gives you much bigger numbers. And what this meta-analysis showed is that to the right or left of this line, the right is low dose was better, the left is high dose is better, and what you can see is that there's only one study that looked like there was any significant difference with a high dose being better, but all of them are kind of on this line, and the consolidated data shows that there was no difference between low and high dose. Okay? Again, the problem with these meta-analyses is that patient populations may be significantly different. Maybe they weren't necessarily prospective studies, et cetera, but pretty convincing evidence between the two articles I just showed you in this meta-analysis that there is some equivalency in properly selected patients. Yeah?
Would there be different recommendations, again, for the pediatric population, or would that be the same?
So the question is about the pediatric population. So there are American Thyroid Association pediatric guidelines that are coming out soon, and those are also where they've been disseminated around for commentary. I must say I haven't read those in as much detail. What I can tell you for us in our practice, so we see pediatric thyroid cancer in our practice with the pediatricians. They come over and we do kind of a joint clinic. And I don't think I have ever given a little kid, more than 100. And that's been when they've had distant metastases. So I do think that 30 is probably going to be adequate for the majority of patients with just neck disease. Now, some of these, young teenagers, they're as big as adults, little adults, pediatrics. They don't like us calling them that, but they're like little adults. And sometimes I've pumped up the dose a little bit on those if they have really aggressive disease and they're over 70 kilos or whatever, over 60 kilos. So I don't know what the exact recommendations are going to be. But again, because they present pretty aggressively, I do feel like they're going to get radioiodine. And this is reassuring that 30 is probably going to be adequate because we don't want to bathe that bone marrow, that growing, generating bone marrow with more radioiodine than necessary. Yeah.
Another question on the pediatric. If you receive that higher end of dose, my son is actually 9 and did receive a higher end dose because of distant metastases. Is there data coming out on the risk correlated with radioiodine in children?
Yeah, so the question is about if a child has distant metastases and gets a higher dose, is there data, sort of long-term data on what the risks are? I am not, off the top of my head, I don't know. I think that as we, have medical records that allow that kind of data to be captured more effectively, which, these electronic medical records are really coming online just in the last few years, I think we'll have that, but I don't know it off the top of my head. I think it's something that, we definitely worry about. And again, it's the idea of we got to treat you aggressively now because you have bad disease, and they need to be monitored. And one of the things we do at the university, and certainly thyroid cancer is a very tiny sliver percentage of this, is there's a clinic called Tactic, which is sort of a transition to adult care and things that these kids and their families need to think about and look for moving ahead that then can also go to the adult physician. And so those kinds of considerations I think are going to be part of that, but I don't know any of the specific details about what the absolute risk is or anything like that. So yeah, here's a preview of the 2014 guidelines. So ATA low-risk disease and even intermediate-risk disease with lower-risk features, 30 is generally going to be favored, okay, is what the recommendation is going to be. So there really is no consensus. I think some physicians, especially who have been doing it a long time, get very nervous. They think that's a very small number. 30 is what most of us in endocrinology will use to treat a toxic multinodular goiter. And how can you treat cancer with the same thing you would use for a non-cancer? But the data is relatively convincing. And what I would say is that most patients are probably overdosed. I think a lymph node metastasis in our practice, when I started doing this in fellowship, lymph node metastases almost automatically equaled 150 millicuries. Just we wasn't even thought about, and that the harm was probably relatively low, but it probably was not much better than 100 or 50 or, and the data, I will tell you, I didn't show it to you, but this kind of 30 equals 50 to 100, there was a whole series of studies that kind of started slowly ratcheting down the dose, 75 versus 100, 50 versus 100, and they were all equivalent, and now we're at 30 versus 100. I don't think anyone's going to go to 20 or 10, I mean, maybe, I don't know. If you have an adequate surgery, you probably don't need a lot of radioiodine, okay? So, post-therapy scan. So, this post-therapy scan is really critical. So what I tell folks is the radioiodine is not just therapeutic, it's also diagnostic. When I give you the radioiodine to mop up anything that might be left behind, we want to see where it goes. Hopefully it only goes here. We always expect it to be uptake in the neck. If we see it uptake elsewhere, we don't necessarily like that, but if it lights up, it's probably being treated by the radioiodine. So for, I must say I have never seen a patient who got radioiodine in my career who didn't have a post-therapy scan, but there was comparisons of patients who only had a pre-therapy scan and no post-therapy scan, had a pre-therapy scan and just got radioiodine. And for those who got a pre-therapy scan and got radioiodine and got a post-therapy scan, lesions that were not seen on the pre-therapy scan were seen 80% of the time, and the stage was changed 10% of patients. Part of that, most of that is because the treatment dose is higher, and we'll sort of, for lack of a better term, drive radioiodine to places that low dose just didn't quite hit the intensity of the one. So post-therapy scan is important. And what we're doing now is in selected cases using what's called a SPECT-CT. So here is a post-therapy scan on a patient who appears to have disease outside the neck. So this is liver, and that's normal uptake, and there's some bladder uptake. But these spots here, that's not something that we expect to see necessarily. And so does this fusion with what's called a SPECT-CT help? So this was a retrospective review of 147 patients who had planar imaging. So this is planar imaging. This is two-dimensional imaging, right? And we always joke with our nuclear medicine colleagues, it's nuclear medicine, we call it unclear medicine, because you can't necessarily see exactly where these spots are. Is that in the arm? Is that in the rib? Is that on the shoulder? I mean, it's unclear. So when they had this fusion of SPECT-CT imaging in this retrospective study, the interpretation of where lymph nodes were changed 22% of the time. The interpretation of distant metastases changed 40% of the time, and the stage was changed in 6%, and the therapeutic planning was changed in 2%. Now, this last point, I think, is what will prevent a lot of centers from adopting this in routine practice. If it only changes your plan 2% of the time, I mean, there definitely is cost and time associated with this. So, you could argue that any information is better, but whether it's truly going to change your plan that's going to make a significant difference in outcomes, I mean, there's no study looking at that. But I will show you from our center an example of this, where this lesion, which maybe looks like it's in the armpit or wherever else, I mean, this was actually in the rib. Okay, and that's significant because bone metastases behave differently than soft tissue metastases. And, you could argue that, I'm not a radiologist, but this is relatively subtle and could be missed if you weren't paying attention. This is kind of an unusual spot for thyroid cancer to go. So, whether that site is going to get radiation therapy, external beam radiation, or maybe even surgery to cut that out. I mean, I think this is useful. And so our nuclear medicine physicians, we work together with them, and they'll use this technology in selected cases where the post-therapy scan is unexpected. And then they can fuse that, and we can get a better sense as to where that disease went.
That's a special kind of CT.
Yep. So the question is about the SPECT CT. Is that a special kind of CT? I mean, it is done in conjunction with the radioiodine, where it can pick up that radioiodine tracer and then, again, fuse that image to just a normal CT scan. But you've got to have that detector to be able to pick up where that radioactivity is.
It's doing both of them simultaneously.
I mean, they can actually, because the radioiodine hangs out, if they do the planar images and they say, oh, we didn't expect that, then they'll kind of not let them go home and run them through the CT scanner. And you got to have that technology. That's as specific as I can be. I don't know the exact technology. So the duration, so radioiodine that's not trapped in follicular cells in general is cleared in 3 days. Certainly patients can clear it faster. Sometimes it takes longer. And then, what's important to remember is that the duration of the effect is actually 6 to 9 months. So radioactivity, I mean, I always used to think about it as, like laser beams killing things immediately, but it's slow. It causes DNA damage, and radiation killing is slow. So the nice thing is, in the absence of something unusual or super aggressive going on, I tell patients, you don't have to see me for 6 to 9 months. It's good for you. Less doctors is better. So because of that, there's almost never an indication to give radioiodine more frequently than every 6 months. I mean, you're just kind of piling on that therapy. And before giving extra doses of radioiodine, the one time when I will use the whole body scan, the sensitivity of those are not as good as the thyroglobulin plus the neck ultrasound, but if I'm considering giving another dose of radioiodine, I get this whole body scan, again, preparing them with a low iodine diet, because I want to see if there's uptake. If there's uptake, I feel very good about giving another dose of radioiodine. If there's no uptake, it's not an absolute contraindication to not giving a second dose, but it makes me less enthusiastic that they're going to get a durable effect, meaning tumor shrinkage or thyroglobulin drop. You kind of won't know until you do it, but when you're getting to that third, fourth, fifth consideration, if you have no uptake on the whole body scan, and especially no uptake on the post-therapy scan and no change in those tumor markers, it's probably not going to work. And that's where we need to start thinking about other therapies. So, in summary, radioiodine is an integral part of thyroid cancer management. The necessity, preparation, and dose of radioiodine should be very patient and disease specific. And again, I think that is where the field is changing. Risk stratification, not based purely on stage, response to that initial therapy, and using things like thyroglobulin and other technologies to determine what dose, if any, needs to be given. So thanks for your attention. We've got about 10 minutes, 5 minutes left for any other questions. Yeah.
I have a question about some of the side effects of the RAI. If you, like I didn't experience, mouth problems or tearing, can I expect that to come on board later on if it did come on right away?
Yeah, so the question is about side effects and the timing. In general, things like salivary gland problems and taste and dry mouth, that's usually pretty quick. I've seen a handful of cases where it seemed like it was more delayed than I expected. The tearing, that certainly can be delayed, but I would say getting over a year out or maybe even 18 months, pretty unlikely. So I think in general, the longer time without it, the better you should feel. And what I tell patients is just, everyone has a very good reason to be very sensitive about their body and considering all kinds of things. But things that are bothersome and persistent and progressive, then you need to let someone know. I mean, because again, allergies, things like that, might pay more attention to it than just regular seasonal allergies. But if it acts like seasonal allergies and it goes away, that's probably what it was. So, and again, the radioiodine stuff, it really is very hard to predict. I've given patients 100 millicuries who had just terrible salivary gland problems. I've given a patient 350 in the context of dosimetry who had 0 problems. So it is hard to predict, but in general, it is a dose-dependent effect for all of those side effects. And the longer you are away from that therapy without problems, it's less likely you're going to have a problem. Yeah. Yeah. So yeah, the question is what is the timing for the post-therapy scan for 7 to 10 days? I believe it is mainly to make sure that anything that's not trapped is cleared. And even though we talk about probably it's cleared after about 3 days. It's just, you still got enough intensity signal to pick up, but you don't want to pick up a bunch of stuff that's not representative of tumors because that scares everybody. So I think that's the timing, and I must say I don't know for sure, and how that was sort of figured out, I must say I don't know. That is the standard, 7 to 14 even, as I've heard. So I believe it's, again, to because we clear radioiodine that's not trapped through urine, through our tears, through sweat, but there's always uptake in the gut. And so, again, we expect to see liver uptake, we expect to see some gut and bladder uptake and salivary gland uptake, but you just don't want to have, something in the midline here that lights up that you say, oh my gosh, that's mediastinal lymph nodes or something else. That's what we call a false positive, and then you go down a path of doing all kinds of workups that making people scared and things like that. So I believe that's it, but I must say I don't know exactly how that came to be. Yeah.
What's the wisdom on protecting the salivary glands? I've heard different things.
And so the question is about protecting the salivary glands. So there have been lots of different things tried without any consistent, clear benefits. So certainly hydration is probably the most common thing that we talk about. Our practice when I was in fellowship and we were admitting more patients than we do now was to have them suck on sour candies to try to stimulate salivary flow. But then there was a study that showed that if you delayed that for 24 hours and give it to them after 24 hours, maybe that was better. But then there was another study that showed that maybe didn't work. There was a study using a drug called amifostine, which is kind of a nasty drug and expensive and has some side effects that maybe was a little bit protective, but that was based on scanning studies looking at the scintigraphy within the glands and not really outcomes. So in general, we always recommend hydration. I think it's very reasonable to try, lemon drops or Jolly Ranchers or whatever you have available. And this starting it sort of right after you get it versus waiting a day, I don't know. So that's about it. Yeah, I think hopefully that if we can get comfortable and confident giving lower doses, then a lot of that goes away. Yeah. Yes.
Where does the University of Colorado fall on that study that compares how regularly you prescribe radioactive iodine compared to other?
Oh, the question is where do we fall? I don't know. I don't know. Yeah. I think we're just right. No, I don't know. I really don't know. They're not listed on there. So Dr. Haymart may know. Maybe I'll ping her. Our big ATA meeting is coming up at the end of the month, so maybe I'll ask her. Maybe I don't want to know. I don't know if I want to know. Yeah. Yes?
What made you get that 350 dose?
Oh, the question was about the 350 dose. It was a patient who had distant metastases that we did what's called dosimetry, where you check the amount of radiation that goes to the lungs and the blood through a series of, you give a tracer dose and you do a series of tests, and then there's an extrapolation. And it was to give sort of the biggest, safest dose in that first dose, because the first dose is usually the most effective.
So it was like non-surgically accessible or something?
Yeah, it was in the lungs. You can't really get to it without causing a lot of damage. Yeah.
So the dosimetry, as I understand, calculates the highest safe dose to the bone marrow. What about the pulmonary fibrosis?
So they do that too. They do what they call kind of whole body scanning counts as well, and they sort of extrapolate that to the lungs, and so it calculates both. And I think dosimetry is in some ways most useful for actually dose limiting. So I had a patient who she was 12. Her CT looked like a snowstorm. There was so much disease in her lungs, totally asymptomatic. And she was a reasonable sized kid. She was 115 pounds or something like that. Maybe not quite that. Yeah, she's close to that. Over 100 pounds. And at that time, this was several years ago, an adult I would have given 200, and her dosimetry dose limited her to 150 because of the potential pulmonary fibrosis. So it was very useful. So I think that's what that's helpful for. It's not necessarily to give the biggest blast that you can. In some ways, it's to be safer with a relatively big. And then so the other context is patients who are, how should we say, more mature-wise, older, who may not have as good renal function and less wiggle room with their bone marrow, and so sometimes they'll be dose limited as well with their renal function. All right, last question. Yes.
So if it's true that the first dose is the most effective, is it always the case that you increase the dose for
So the question is do we always, or is it true to always increase the dose with second and third doses because the first dose tends to be more effective? That certainly tends to be the pattern, and that is our pattern. I mean, the idea is that you've zapped these thyroid cancer cells that probably aren't going to be as responsive, so pump up the dose to just hopefully get more radiation in there if they're a little bit, less responsive, don't want to take it up as much. So we tend to do that. I mean, the idea is that if you give 100 and there's still disease, well, 100 wasn't enough, right? So it's a combination of that 100 didn't eradicate it, and it's probably been altered with that dose, and so we tend to give higher doses, and there's no formula for how to do that. All right, thank you for your attention.